Yes, same kind of guy. Let's talk about cyclooxygenases in this video before going deep into the pharmacochemistry of different NSAIDs. Here is what we are going to talk about. We are going to introduce our topic. We talk about the differences between COX1 and COX2, their affinity for the COX enzymes, the NSAIDs activity, the selective and the non-selective NSAIDs. Then we talk about why aspirin can be given at low doses to prevent heart attacks, and at higher doses it is used as an analgesic. We talk about the paracetamol. Why is it not an anti-inflammatory drug, yet it is antipyretic and analgesic? We talk about the side effects of NSAIDs, those that are selective and the non-selectives, and we talk about the prevention of the side effects. Yes, please don't forget to subscribe, like the videos, and share. Yes, as we said that in the previous videos, cyclooxygenases, these are enzymes which convert arachidonic acid into the prostaglandin, prostacyclins, and thromboxanes. From arachidonic acid, we go to prostaglandin G2, then prostaglandin H2. Here, we can get different compounds. We can get the prostaglandins, the E2 and F2 alpha, and prostaglandin D2. Also, you can get the prostacyclins, also the thromboxanes, the A2, then to B2. Then for cyclooxygenases are the enzymes which convert this arachidonic acid to prostaglandin G2 and F2 alpha, as they have two active sites. It has the COX active site, and the peroxidase active site. When the arachidonic acid comes to the COX part, it is converted to prostaglandin G2. Then after it goes to the peroxidase active site, it's converted to prostaglandin H2. So that's the cyclooxygenase. Now, the difference between COX1 and COX2, we have COX1 and COX2, but they are a bit similar, just with a few differences. COX1, these are the structures. This is COX1. This is COX2. COX1, generally, it is constitutive. It is always there in the body, playing its role, the housekeeping. For example, in the GIT, it leads the production of the mucus. Also, it leads the production of the gastric acid. And also other roles in different sites where they are found. This COX1. But COX2, mainly it is induced. Apart from a few areas. For example, in the brain, it can be constitutive, always there in the brain. Then some parts of the kidney. In the kidney, it leads to the urine flow, the urine output. In the fetus, in the ductus arteriosus. This COX is always there. In the blood vessels. This COX2 in the blood vessels, it prevents coagulation as it produces the prostacyclin. This prostacyclin, it antagonizes the effect of the thromboxane. So this one prevents the coagulation or the clotting. Prevents clotting. But for COX1 in platelets, remember we said that all the tissues, they have COX enzymes, but the further enzymes for the production of further prostaglandins are different in the different tissues. For example, in platelets, it has COX, but mainly COX1. It has COX1. Then another enzyme which is present is the thromboxane synthase. So after the formation of the prostaglandin H2, thromboxane synthase will convert the prostaglandin H2 to thromboxane H2. This one is responsible for the clotting. So the prostacyclin, as it is produced from the prostaglandin H2, then after prostacyclin synthase, then it converts the prostaglandin H2 to prostacyclin. This one antagonizes the effect of this one, such that there is no clotting in the blood vessels. Now, COX1 also, it is more selective than COX2. This COX1 is more selective than COX2. Then for COX2, this one can accept fatty acids like arachidonic acid, and also other fatty acids which are carbon 18 and carbon 20. This is carbon 20, but for this one, it's more selective for arachidonic acid. Structurally, this is COX1, this is COX2. COX1 has a sequence of amino acid. It has amino acid sequence at the N terminal. This side. So when you are joining the amino acids, remember we have a carbon, we have a central carbon, then we have N. Then here, this side, we have the carboxylic acid, we have H and the R group. So mean that if you're joining another amino acid, it will be like this. It will be like this. Here we have the NH2 and the R group. So if we are joining, mean that we shall lose water. So if you are making a long chain, meaning that this side you have a carboxyl group, the other side you have the amine group. So this is the C terminal, the carboxyl terminal. This is the amine or the amide terminal, where we have the NH2. Now, for the COX1, it has the sequence of amino acid at the N terminal, which is different and it's not there in COX2. But for COX2, has a sequence of amino acid at the C terminal, which is not there in COX1. So this one is a 18 amino acid sequence. This one is a 17 amino acid sequence. So this one has a sequence of amino acid at the C terminal. Now, another thing, you see that here we have two amino acids. This is isoleucine and this is isoleucine. At position 523 and 434, isoleucine. But for COX2, instead of this amino acid, it has valine. In the same positions. We have valine. And this one, you can see that it's a little bit bigger than this one. This is smaller, this is larger. We shall talk about this also. So those are the main differences. COX1 mainly is constitutive, so it's there in many parts of the body. COX2 mainly it is induced, though there are some areas, other sites where it is constitutive, like in the brain, kidney, fetus, and in blood vessels. Those are the main differences between COX1 and COX2. Yes, let's talk about the affinity of different NSAIDs. NSAIDs say that these ones are the drugs which inhibit the COX enzymes. Remember, COX, you have COX1 and COX2. We have the non-selective. These ones, they can bind to COX1 and COX2 with almost same affinity. Though some have higher affinity for COX1 than COX2, but it's not a general thing that it's a must. They must have higher affinity for COX1 than COX2, apart from some few drugs. And we have also the selective COX2. These ones are called the COXIBs. Let's take one example. For example, the celecoxib. When you look at the structures of these drugs, they can fit in the COX2 enzyme, but they cannot fit in COX1. So they have an extra part which can only fit in COX2, but not in COX1. When you look at COX1, we have these groups, the isoleucine in COX1. These two amino acids, the isoleucine. They act like a gate. They close this part, meaning that if a drug binds, it won't fit this side, so it can only occupy this region. But in COX2, we see that the amino acids present, they are a little bit smaller. They can allow the drug to bind at this position. So for arachidonic acid, it should also bind to the COX enzyme. And the carboxyl group, remember their structures. The prostaglandins and the arachidonic acid. We have this. This is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So this is just a sketch. They have the carboxyl group and they have this ring and another chain with the alpha hydroxyl group. So this one binds at this amino acid. This is adenine. This is adenine. The carboxyl group binds to the adenine. Then these other parts bind to this position. Now, for the NSAIDs, for the celecoxib, for example, we have this structure. We have this structure. This is celecoxib, and it is a selective COX inhibitor. Now, aspirin. We have aspirin. This is the structure of aspirin. It has a carboxyl group, and it has a styro group. This is aspirin. This is celecoxib. Now, this sulfamyl group, this group here, this sulfamyl group can fit in this region. This is called the allosteric pocket. So this bulk group can fit in the allosteric pocket and it is stabilized by the arginine. This is arginine in the allosteric pocket, which is not present in the COX1. So the selectivity for COX2 is due to the different groups in the selective COX2 inhibitors, the COXIBs. This sulfamyl group fits in this region, and for that, it can be stabilized by arginine. But for aspirin and many other NSAIDs, they cannot reach this region because they don't have this bulk group, but they can inhibit COX2, but they are not selective for COX2. They can also inhibit the COX1 because they only bind at this region. Now we have a question. Why is aspirin given at lower doses to prevent heart attacks, then at higher doses can be used as analgesic and antipyretic? For aspirin, this is the structure of aspirin. At low doses, aspirin has higher affinity for COX1 at lower doses. And this effect will be more in platelets. In platelets, remember, platelets, they have COX1 enzyme and thromboxane synthase. Which form the thromboxane A2. Then, meaning that these platelets, they are responsible for clotting. And remember that platelets, they don't have nucleus, meaning that whenever they are inhibited, the COX is inhibited, there's no more synthesis of COX. For them, they have COX, but this COX enzyme is present from the formation of the platelets. So whenever it is inhibited, there's no more synthesis of the COX because they lack nucleus. So meaning that the effect will be more in platelets than other regions. So if aspirin inhibits the COX1 in platelet, it can also inhibit the COX2 in the blood vessels. Meaning that the prostacyclin or the prostaglandin I2 can also be inhibited. But because the cells of the blood vessels, the endothelium of the blood vessels, they can regenerate more prostacyclin. So this effect is not pronounced here. Also, the effect in the GIT at low doses will be low because also in the GIT, the cells have nucleus. They can synthesize more prostaglandins. So mean that aspirin at lower doses has more effect on the platelets because they lack nucleus. But at higher doses, mean that also the COX2 can be inhibited, mean that the prostacyclin, the inhibition will be higher than the formation of the new prostacyclin blood vessel, which antagonizes the effect of the platelets. And also in GIT, we can have side effects because the prostaglandins, which are responsible for the housekeeping in the GIT, they are also inhibited. Mean that at higher doses, in case of inflammation and pain, we can inhibit we can inhibit the COX and prevent the inflammation and pain because all the COX enzymes, they are inhibited. So why is paracetamol not anti-inflammatory drug, but it's only analgesic and antipyretic? Here we come to COX3 enzyme. It is said that paracetam inhibits the COX3 paracetam, and this COX3 is not responsible for the inflammation, but mainly it is responsible for the pain. And this COX3 mainly it is in the CNS. So whenever this COX3 is inhibited, the pain will go. So that's how paracetam inhibit or lead to analgesic effect, because it inhibits the COX3, and this COX3 mainly it is in the CNS, not in the peripheral. So we shall have analgesic effect of the paracetamol. Now let's talk about the side effects of these COX1 inhibitors and the COX2 inhibitors. Yes, also know that aspirin is the only NSAID which permanently inhibits the cyclooxygenases. This is the structure of aspirin. This is the structure of aspirin. It has this acetyl group here. This group is cleaved off and permanently acetylate this amino acid here. This is serine. The serine is acetylated by the aspirin. This is aspirin. So mean that this group here we shall have this. This is cleaved off, so we shall have this group like this. So meaning that the arachidonic acid no longer fits in the receptor site. So meaning that there's no more prostaglandin synthesis because arachidonic acid cannot fit. It's the same serine here. Here. It's the same serine. It is acetylated. After acetylation, arachidonic acid cannot fit to form other prostaglandin. That's how aspirin permanently leads to the inhibition of production of prostaglandins, and it's the only NSAID which permanently inhibit the cyclooxygenases. For the side effects, remember that NSAIDs, as we have said, they inhibit the prostaglandin production. These prostaglandins, remember, they are the pain mediators and inflammatory mediators. So they can increase the pain sensation. Now, but for the non-selective inhibitors of the COX enzyme, meaning that we shall have a decrease in prostaglandin and also a decrease in leukotrienes. But depends. If non-selective but has higher affinity for the COX1, means that if this one is inhibited much, the prostaglandins are inhibited much, the other pathway is enhanced. Remember, we have two pathways, the COX pathway and the LOXY pathway. So if this one is inhibited, means that more arachidonic acid will be used for synthesis of the leukotrienes. And these leukotrienes, remember, they lead to bronchoconstriction. So if these ones are synthesized more, meaning that in asthmatic patients, things can go worse. So they can worsen asthma. The NSAIDs, those which have higher affinity for COX1, they can worsen the asthma. NSAIDs, the likes of aspirin, the indomethacin, and other NSAIDs. They can worsen asthma. So their use in asthmatic patients is contraindicated. So that's one. Also, the GIT bleeding, pain, because they lead to the reduction of the prostaglandins. And remember, we said that prostaglandins, they are always present by their activity leads to the increased mucus production and reduced gastric acid secretion. So if they are inhibited, means that we shall have GIT bleeding and pain. For the COX2, COX2 selective, or the selective COX2. The selective COX2, these ones, they inhibit the COX2 enzyme. Remember, this COX2 is responsible for the prostaglandin, prostacyclin production, and this one prevents the clotting. So if it prevents the clotting in the blood vessels, so if it is inhibited, we can have increased risks of heart attacks. They have increased risks of heart attacks. Also, as we have seen the structure, for example, the celecoxib, there is a sulfamyl group, and meaning that for patients which have allergy to the sulfur groups or the sulfur, they can also have allergy to these drugs. So they can lead to allergic reactions in those patients who are at risk. Those are the main side effects. Now, how is it prevented? Now, NSAIDs, for example, in GIT, this side effect can be prevented. For example, in case the NSAID is used as analgesic, it can be given with some prostaglandin analogs to prevent the GIT bleeding. For example, misoprostol. This is a prostaglandin E agonist or analog. So, NSAID can prevent the pain. Then this one protects the GIT against the side effect of this NSAID. For example, in Atherotech, the combination of the misoprostol and diclofenac in treatment of rheumatoid arthritis, it is used. Another side effects, we can have the kidney injury. And fluid retention. Remember, we talked about the advantage or the importance of these prostaglandins in the kidney. So if it is inhibited, mean that you can have kidney injury and fluid retention. For this video, let's stop here. Please don't forget to subscribe, like the videos, and share. More are coming. Yes, same guy.